Hey guys, welcome back. Just give me a hello in the chat if you can see and hear me okay, please. Perfect. Thanks everyone. I'm sorry about what happened before. Still don't quite know what happened, but YouTube decided to just die on me. So I had no video and no audio, but hopefully Zoom's a little bit more reliable, so I think hopefully we'll be all right. So all right. What's that happening? Am I still there, guys? Perfect. Sorry, I don't know why it keeps doing that. Um, right. So yeah, I'll make a start and share my screen. So um, let's make a start of it. Right. So I'm going to share the Menti details again. So you can either join using the QR code or with the link. I'll let you choose what one you want to do. So guys, the session will be recorded. It'll be available for you to watch back for a couple of weeks afterwards, I think. So it will be uploaded onto YouTube, but it'll just be a Zoom recording rather than a YouTube live, if that makes sense. No, for those asking if I can see you, no, I can't. So it's a webinar, so you guys are just tuning in. It's only me that's visible. Right, yeah, don't worry. So it will just say waiting for the presenter at the moment. There's the Menti for anyone that's not used it is to keep it interactive, so it lets you guys send in answers to some of the questions and things like that. But yeah, for people liking it, it's because there's loads of you in here at the moment. So you know, if the chat is kind of whizzing through, it will just lag a little bit. I'm afraid there's not much I can do about that. Right. So yeah, we'll be here for an hour, guys, for those of you asking. Right. And so just to intro myself for anyone that wasn't here before. So my name is Mustafa. I'm a doctor. I've kind of got two different roles at the moment. So I've been a doctor for coming up to 10 years now. So I'm getting a bit on the old side. So I did initially train as a GP. When a GP, for anyone asking, is a general practitioner. So that's like a family medicine doctor in the UK. So I initially did that, and I still do that for kind of 1 or 2 days a week. But I'm now kind of working in a different specialty, which is called sport and exercise medicine. So that's a specialty which deals with musculoskeletal problems mainly. So joints, muscles, tendons, that sort of thing, and that obviously overlaps with sport injuries as well. So most of the time I do that. You don't have to join Menti, guys, if you don't want to, but it will make it, I think, more beneficial for you if you do. Right. So hopefully everyone's joined. I'm going to start with a bit of an intro piece, just about talking about work experience in general. So, um, let me know your thoughts. Why is work experience important? So this will be a word cloud, so it'll be kind of hopefully highlighting the main things people are sending in. And hopefully the word cloud is usually quite good at picking out the common themes. So hopefully if we get those common themes, then we'll have something to go off. Okay, so we'll stop it there. I think that's quite a nice little starting point. So obviously we've got the word experience, which is true. You're obviously trying to experience the thing that you're going into. I think the next few words are really important here. So people have talked about insight and understanding, and I think that's really accurate. I think a lot of work experience is about knowing what you're getting yourself into. So I always say to people that medicine is quite different to a lot of other careers in that when you're applying for university, so at the age of 17, 18, you're basically at that point applying for your future job as well. And that's quite different to a lot of other career pathways. So let's say you did maths or physics or history or whatever it is at university. You're just applying for a university degree, and then at the end of that, there will be multiple different career options that you might want to go into, and then you'll decide at the end of the degree. Whereas medicine is different. You're applying for your job at the point of applying for university. So in the same way that, if you were applying for a job, you would be expected to have, some experience and some insight into the thing that you're applying for. The same thing is true of medicine when you're applying to university. So you're expected to have that understanding of what the job is and that insight. Alongside that, I think it's important that work experience shows some of your own skills as well. So your own skills and knowledge. It's a way to showcase that, which I think people have touched on here. Um, Confidence, yeah. And the last thing, which I can't see on here on the obvious side. So we've talked about making an informed decision. Okay, so that's kind of knowing what yourself getting into, and we've talked about how it can help you show some of the skills and attributes that you need, which is important as well. The middle one is also important. So by doing work experience, you're giving up your own time to go and do stuff towards this future career that you're thinking about. So that in itself, the fact you're choosing to be here rather than, I don't know, doing whatever else, that in itself does show you're motivated and you're committed. Sorry, excuse me. That shows you're committed and you're motivated. So that in itself is quite powerful too. So the next little question I've got here is what counts as relevant work experience? So what can people think of that would count? And again, hopefully we'll get some important themes here. Cool. I'm going to stop the voting now just so it doesn't get crazy. Right, but I think the most kind of important themes again are in there, which is really good. So the thing that people always talk about with work experience is shadowing. So that could be in a GP practice, which I think people have mentioned, or in a hospital. So you're kind of watching, observing doctors, and I guess an internship would be kind of a different version of that as well. Um, so, um, yeah, I think internship, shadowing, that kind of means the same thing. And then the other big one is volunteering. And you could be volunteering either in a care home, in a nursing home, in any kind of place where you're kind of looking after people and helping in that sense. So, um, I guess to kind of move on to the list that I've made, this is the kind of list. So yeah, we've got shadowing and observing doctors. You've obviously got work experience programs and courses, a bit like what we're doing here and what pre-med projects do. A lot of. There's also volunteering, and I've said especially with vulnerable and disadvantaged people, and those are kind of the obvious ones. But actually, beyond that, there's also things like mentoring and teaching colleagues, especially younger ones, and doing paid jobs, and that can count as work experience as well. And I guess the next question is what is it that would make something count as work experience? And that's where I think this slide is really, really key. So this is taken off a website called the Medical Schools Council, which is an organization that kind of oversees all the different medical schools and provides guidance. And they've actually produced a document that it essentially outlines what work experience is supposed to be for people in your position. And what it talks about is three different areas. So the first one, if we go through them one by one, is people-focused experience of providing service, care, support, or help to others, and to understand the realities of working in a caring profession. So, what does that mean in real terms? Because that's very wordy, isn't it? So, people focused experience, they want to see that you've got people skills, they want to see that you can talk and communicate with people and work with people. And ideally, they want you to be able to do that in a caring or supportive role of some sort. The other next point is that you've developed some of the values, attitudes, and behaviors to being a doctor, such as being conscientious, good communication skills, and interacting with people. So again, there's more people skills in there. There's a lot about communication and some of the other different skills that you might need to have as a doctor. So teamwork, leadership, being conscientious, and just generally being honest and a good person. So these are all things that you need to show, because those are all things that you would then need as a doctor. A realistic understanding of a career in medicine and the physical, organizational, and emotional demands of a career. So this is the one about insight and understanding that we've talked about, that do you know what you're getting yourself into? So I think it's important to break it down into these three areas, because whenever you apply and whenever you submit your application, it's really important that you kind of cover all three of these bases. Have you showed that you've got people skills, ideally in some kind of caring or supportive role? Have you showed some of your other skills and attitudes and behaviors? And do you have a realistic understanding of a career in medicine? Okay. So cool. What I'm going to do is I'm now going to show a list. Sorry, go back to the list. And I want us to kind of just have a think, and you can use the chat for this a little bit now. So if you were shadowing or observing a doctor in hospital, let's say you were in a clinic and you were watching a doctor see patients, which of the kind of 3 points that I've outlined here do you think that would help with? So 1, 2, and 3 out of those. So there's a bit of a variety. I think most people are saying 3. Some people are saying 1 as well. So if we think about it, guys, if you're just shadowing and observing someone, that doesn't allow you to show any of your own skills. Okay? So mainly if you're shadowing and observing, whether that's in a GP practice, in a hospital, anything else along those lines, you're only really going to be able to tick box number 3. So it will give you a realistic understanding about medicine and the demands and what's involved, but it's not really going to show your own people skills, is it? Because you're just watching, you're not really doing anything. And similarly, it's not really going to allow you to show off any of your own skills, because again, that would require you to be doing more stuff. So people always talk about shadowing being really important and these internships and observing stuff, and it is helpful, it is good. But I think one of the main points I want to make here is that it's a bit overrated in some ways, because it gives you that understanding, but it doesn't actually help with the other aspects of what work experience is supposed to show. So do it by all means, but you need to make sure you're combining shadowing with something that allows you to showcase your own skills. And that's where I think volunteering is really great. So if you're volunteering in a nursing home, in a hospital, in anything else, so we'll that kind of is really beneficial, because that not only kind of gives you some understanding of a healthcare setting, but it definitely gives you people skills, because you're working with people, for people, in a team, and you're also showing off some of your own other skills as well. So I would really, really kind of advocate volunteering. Guys, just if we can try and keep the chat to just answering the questions, please, because I don't want to turn off the chat, but there's obviously a lot of us in here, and if people are just kind of trolling and it's kind of annoying everyone else, I'll just turn it off. So please just chill and use it for the session, please. So volunteering, again, people are asking about other types of volunteering. So as an events ambassador, or as in a charity shop, any of those types of things, yes, it all counts. So any volunteering where you're working with people as part of a team, you're showing those people skills and those other skills, that counts as work experience. Okay, it is relevant. Now, ideally, it's even more kind of valuable if you're doing it in a setting where you're kind of caring or supporting others. So if you're looking after maybe people with a disability, or who are physically impaired in some way, or any of those types of things, that makes it even more valuable. And that's where work experience courses and things come in as well, because through these types of courses, hopefully we're going to give you some of that, to kind of reference this again. We're giving you number 3, hopefully, because we're kind of giving you a realistic understanding of what to expect out of medicine, but also you will hopefully have some opportunity, especially on more face-to-face courses, to kind of show your own skills as well, to work in teams, to do different exercises and things like that. So a lot of people are asking, is volunteering here? Does this count? Does that count? The answer to the question, guys, is on this page. So if it shows any of the things that I've got on this page, then it counts. And it can be paid. It doesn't matter if it's paid or not paid. If it's experience, it's experience. So yes, absolutely does count. Virtual work experience people are asking about will normally help with number 3 because it's giving you that understanding. But if you're doing something virtually, it's normally going to be limited in how much you can show your own skills. Okay, so it would be mainly about number 3 if you're doing something virtual. But maybe, if you were participating in some kind of activity, it could be others as well. So, and people asking about kind of, how these sessions can help. So in any work experience that you do, what's most important is that you kind of interact and you ask questions, okay? Because anytime you do that, there's really good research that shows the more you interact and ask questions, the more you understand and the more you remember. Remember, whenever you go to any work experience, the reason that you're going there is not to learn medical knowledge, right? So you're not here to learn about a particular medical condition and then you can go and diagnose that. You have 5 or 6 years of medical school to do that afterwards, okay? So that's not the goal. It's a bonus, obviously. Hopefully you find it interesting. But the main thing is that you want to reflect. So you want to think about, what have you learned about medicine as a career? How has this influenced that your own desire to do medicine? What skills do you need to work on? And I always recommend to people, keep a diary and a log of what you've seen and learned. That includes today, that includes these virtual sessions, that includes your volunteering that you do, that includes any observing or shadowing that you do. So just keep a log and really try and reflect. So the main thing that I want to talk a little bit about today is something called history taking. Okay, so this is hopefully a little bit of a taster, and I understand that you guys are also going to be tuning in tomorrow evening, where we've got a bit of a case session, and hopefully this will transfer nicely onto that, because it will kind of show you, it will help you kind of understand how we're working through a case when we do that. So the idea is, if you can understand today's session, it will then help to kind of make tomorrow's session and the other ones a little bit more beneficial and a bit more interesting. Tomorrow's 7:30 for those asking. People always ask about certificates. So yes, there is a certificate at the end of the course. I think there'll be a short kind of quiz that you'll have to complete to show that you've learned the stuff, and then yeah, you'll get a certificate. So the first question is here. So this is a multiple choice one. So when a patient comes into hospital or a GP practice, what is our end goal as a medical team? Cool. So some of you are being very sharp and you're saying all of these, which is absolutely correct. Okay. So it is all of these things. So, some diseases will be curable, which is great. If we can cure them, we'll do it. So something simple like a chest infection, give them some antibiotics, they'll get better. Great, we can cure it. Other diseases, we can't really cure them, unfortunately, but we can give advice and we can give medications and sometimes surgery to help improve their symptoms. So we can't get rid of the underlying problem, but we can improve their symptoms. There's a big thing now in medicine about prevention. So some of you might be familiar with the NHS's new kind of future plan, which gets released every now and then. It's if you haven't looked at that, that's something really worth looking at, and I'd recommend, because when it comes to your application and interviews, these are all things you really need to be aware of. So look up NHS future plan. And a big thing on the future plan for the NHS is to prevent future health problems. So this idea of prevention, if we can prevent diseases and prevent problems, that's much better, and also actually much cheaper in terms of the health system, in terms of you know prevention is better than cure. Essentially, is what that's saying. So and yes, through all of these things, we can improve their quality of life. And sometimes improving the quality of life might not even be through something medical. It might be something we can do in terms of their emotional well-being. It might be something we can help with in terms of their home setup. It might be more of a social problem where we need to help them with getting carers or things like that. So it can mean a lot of things. So I guess the first thing to say here is our job as doctors is not necessarily one thing. It's not just curing disease or saving lives. It can look like a number of different things. Okay. But what's really important in order to be able to do any of these things, whether that's making symptoms better, that's curing, that's preventing, that's helping in other aspects of their life, we need to get to this idea of a diagnosis. So hopefully a lot of you will already be familiar with the term diagnosis, which basically means figuring out what's wrong with someone. Okay, so identifying the problem, figuring out what's wrong. In medicine, we call that a diagnosis. And it's only after getting to a diagnosis that we can then figure out what the next step is in terms of treatment. Now, that treatment could be any of the things that I showed on the last slide. So it could be curing, it could be helping symptoms, it could be preventing future complications, could be a combination of all of those things. Okay, so what I would say is diagnosis is really key to be able to get on to the next bits. And most of the time at medical school, most of what you learn at medical school is to do with getting to this diagnosis. Because actually, once you've got the diagnosis, a lot of the treatments and things you could almost look up in a textbook, or you could go on ChatGPT and be like, what is the treatment for this? And they would give you some of the treatments. The thing that, machines and that aren't good at, and the thing that you can't kind of just learn out of a book, is how to get to a diagnosis in the first place. That's where there's a little bit more of an art, and where it's a bit more difficult. All right. So the next question I've got for you guys is, what tools can we use to help us get to a diagnosis? Okay. And those of you saying history, it's very perceptive, because that's obviously what the session is titled. So that's a good one. But let's see what else people come up with. Cool. We'll stop it there because there's lots of responses already. Cool. So people talking about history and symptoms, those are more or less the same thing. All right. So when we talk about taking a history in medicine, all that really means is that's us having a conversation with the patient. So any information that you get from asking the patient questions and having a general chat with them, that's what we call a history in medicine. Okay, so it sounds a bit like technical and a bit fancy, taking a history, but it's just having a chat. Basically, you're just having a chat and asking the patient questions about why they've come in. And that includes the symptoms that they've got. In fact, that's probably the main thing that you're going to ask about more than anything else. But it also includes some of these other things that you guys have mentioned in here as well. So someone's mentioned family history, someone's mentioned medical history. All of these things would come under the history. So any kind of question that you're asking someone about why they've come in, that by definition is part of your history. Okay? Then other things people have mentioned, which is I think quite nice, is different types of tests. So a couple of mentions of blood tests, which is great, and then different types of scans as well. So people have mentioned MRI scans. I think there was X-rays on there as well. So all of those are different types of scans, different kind of different types of imaging that we can use as well. So that's great. Other than that, so someone's mentioned a stethoscope, which is great. So stethoscope is something we use to examine a patient, and examining is very different to a history. So history, for anyone that missed what I said before, is when we ask questions. An examination is when we observe things ourselves. So that could be from looking, it could be from listening, it could be from touching, but anything which you can objectively measure on the patient yourself, as opposed to just asking them questions, is more examination compared to history. Okay, so history is kind of subjective, it's where you ask the patient questions, and examination is objective, where you are assessing things on the patient from look, listen, feel, all of these types of things. Okay, so I kind of break this down into a bit of this kind of spider diagram type thing. So to get to a diagnosis, we talked about history, so asking the patient questions. Examination, that could be any different part of the body. We've then got things like bedside tests. I think people mentioned ECGs on the slide before as well, which is a good example. So these are quick tests that we can do right next to the patient, which give us immediate results. So an ECG is a test where we do an electrical tracing of the heart to see how it's beating. And we can also do urine tests, so things like testing for infection and pregnancy, which give us a pretty instant result. Okay. On top of that, we've got more general tests like blood tests and scans, but those do take a little bit longer. Okay. But that again will give us valuable information. And then people also talked in the last slide about observations, or what we call vital signs. So observations, vital signs, very similar things, which are particularly important in emergencies. Okay, so this is things like heart rate, respiratory rate, which is how fast you're breathing, blood pressure, oxygen saturations, and temperature. Okay, so there's 5 main vital signs. And vital signs are very important, especially in emergency type situations. So when someone is very, very unwell, let's say they've come in unconscious, or they're having a heart attack, or they're having some other kind of serious medical emergency, vital signs are the most important thing in those situations, because in that situation, the patient can't really talk to you. It's very urgent in terms of time, and these things give you a lot of information very quickly, and they will tell you a lot about if someone is deteriorating or not. So we kind of take all of these things together. These are all the different tools in our toolbox, if you like, and we use those to get to a diagnosis. Okay. And as we talked about before, once you've got that diagnosis, then you can talk about the next step in terms of curing, treating symptoms, preventing future problems, all of those other things. Okay. So out of those things that I've listed, guys, what do you think is the most important? So they are all important, guys, but there is one which is the most important. So in this one, the most important is definitely the history. Okay. Now, whenever we ask this question, a lot of people say vital signs, and you're kind of not completely wrong, because in some situations, as I talked about, if you're in an emergency situation, let's say your patient is really unwell, they're unconscious, or they're kind of so out of it that they can't really talk to you. We talked before, history requires you to ask the patient questions. So if the patient can't talk to you, history obviously becomes a lot less important, and vital signs become a lot more important. Okay, so in emergencies, you're absolutely right. Vital signs are the most important. But thankfully, in medicine, most of our work isn't emergency work. Most of our work is with patients who aren't about to die. And in those patients, the history is the most important. Okay. So the next question is why the history is the most important. And that's hopefully going to be demonstrated on the next slide. So this is one where you should be able to rank the different ones. So what I'd like you to do is order these in the order that we would do them. So what would we do first and what would we do last in this kind of sequence of things? So remember, this isn't most important. This is like the order in which you would do things. Okay. So guys, all of you, most of you have said history first. Why is history first? So if you put history as the first thing you do, why is it the first thing you do? It's the easiest. Oh, I disagree with that. It's probably the hardest to do, actually. There's too many responses in the chat. Gives insight, understands the patient. Sorry, guys, I can't keep up with the responses. There's too many of them. Um, cool. Right. So the reason the history is the first one and is also the most important is the history lets you narrow things down. Okay? Because remember, when a patient walks in, they could have absolutely anything wrong with them. And if you have absolutely no idea what's wrong with them, what tests are you going to do on them? Like, if you start doing blood tests on someone where you've got no idea what's going on, are you going to go and do 100 different blood tests? Are you going to scan their whole body? Are you going to examine their whole body? You'll be there forever and it'd be really, really expensive. So, and you probably won't even get your answer because there'll be so much information that you won't be able to figure out what's true and what's not. Guys, please stop the trolling. I will have to turn off the chat. All right. Um, so, um, so the history is important because it kind of helps to sort of narrow things down. So what we talk about is this idea of a differential diagnosis. Okay, so the idea of our patient history is that we take a history, and at the end of the history, we come up with something called a differential diagnosis. So this is a list of a few possible things that could be wrong with a patient that could be causing the symptoms. We don't have to drill it down to just one thing, but maybe four or five of them. And then we can use the other tools, things like scans and blood tests and examination, to kind of rule in and out those things to get to our final diagnosis. But if we don't even have this provisional narrowing down, then it becomes really hard to do any kind of scans or tests or things because there's just so many things that could be going on. So the history gives context, it helps us narrow down. Then we go to examination and vital signs you kind of do at the same time. So those two would almost be together. So, you know, you check their heart rate and their blood pressure and their breathing rate at the same time you would listen to their chest and their heart. You might, you know, check their nerves and other things as well at the same time. Then you would go on to bedside tests, absolutely correct. So that's where you would do things like an ECG or check their urine. Then you do blood tests and scans last. Okay, so that is the correct sequence. You guys are absolutely spot on. Okay, but the most important thing I want you to take away is that the history is the first thing you do because it narrows things down, and then it then allows you to focus the next things that you're going to do after that. Cool. So in summary, we use our history to get our differential diagnosis. We then use our other tools to kind of narrow it down. And once we have our diagnosis, we eventually get we can eventually decide on treatment. So the next thing I want to look at here. Sorry, I think my Menti's just got a problem. Just bear with me a second, guys. Stu-du-du-du-du. Don't worry, guys. It's not. I'm not going to all go down again. I've salvaged it. It was just a problem with the Menti. Cool. So when we take a patient history, I'm going to give you a little bit of a framework of the important bits that are in there. So when we start a history, okay, there's a few kind of really important things we need to do at the start, and these sound a little bit obvious, okay, but they are really important. The first one is to introduce yourself, and that sounds again really, really obvious, but if you walk into a room and there's a patient there, and you just start asking them questions about their heart or their brain or whatever, they're quite, remember, if anyone's ever been a patient, it's quite an anxious kind of position to be in. You feel worried, you feel quite stressed. And if someone just comes and randomly starts asking you questions, it's really quite jarring and you don't feel good about that. So actually just introducing yourself, saying who you are and what you're there to do kind of really helps to orientate the patient and to get them on side. Um, and a big part of history taking, remember, we're getting information from the patient, but at the same time, we're trying to build this relationship and this rapport. So, again, another one of the reasons why history taking is so important, as well as the actual information part and getting to the right diagnosis, you need to build a relationship and a rapport with your patient so they trust you. If the patient doesn't trust you, they're not going to kind of invest and believe you when it comes to the treatment and the diagnosis. So, this is your chance to build that trust. And that starts from the first moment you walk into the room and from when you introduce yourself. So, saying who you are and just say, look, I'm going to start by asking you a few questions about why you've come in, which is what the history is. That will help them to understand, okay, well, this is why he's asking me the questions and I know what to expect now. Um, and part of that is also consent. So consent is the idea of asking permission. And for some things, consent is really obvious, right? So if you were going to do a surgery on someone, there's a formal consent a form of paperwork to fill out. If you were going to take a blood test, you obviously have to ask someone's permission before stabbing them with a needle. With history taking, it's a little bit less obvious, okay, in that you're just having a conversation, but it is a good idea just to say what it is you're going to do, why you're doing it, and just to say, look, some of the questions might be a bit sensitive, but it's all confidential. It's just going in your medical record. And that'll help people feel reassured and to trust you as well. And then after that, we would always start the history with what we call open-ended questions. Okay, so an open-ended question, as some of you may already know, is a question where you can't just give a yes or no answer. So let's say a patient comes in and you say, are you in pain? That's a yes or no question. Do you have a cough? That's a yes or no question. Okay. So those are closed questions. There are also questions which are slightly more closed and not completely open. So if you ask someone, where is your pain? That's not a yes or no question, but it's still quite a closed question because there's only a kind of narrow spectrum of answers that someone can give for that. If you ask, when did your cough start? Again, that's quite a closed question because even though it's not a yes or no question, they have to give kind of quite a restricted answer to that question. So we want to start as open as possible. So the questions I always start with are, what's brought you in today? Or how can I help? Or tell me what's wrong. Things like that, okay, where it's really, really open-ended and the patient can pretty much say whatever they want in response to that question. And this is good for two different reasons. The first one is it's really, really good for guys, please stop it. Okay, I'm gonna turn off the chat in a second, right? Last warning, genuinely. Okay, cool. So what I've lost my trail of thought now, right? So um open-ended questions, right? So if we start with an open-ended question, it gives the patient a platform to then talk, okay? And if the patient has a platform to talk, they then feel like they've had the chance to express the things that they're worried about, that they've got everything that's in their head over to you, so you have all the information. If you've ever been to a doctor and you've kind of, not had the chance to say what you want to say, then that's quite frustrating and you feel quite worried and kind of unsatisfied. So it actually helps the patient to feel like they've been heard. And again, that then all feeds into this idea of being able to build that rapport and that relationship. Okay, so really important there. And also, it's a really efficient way of getting information. If one person is talking and you can just be jotting your notes while they're talking to you, then that's really efficient in terms of getting information. Whereas if you have to ask loads and loads of questions to get that same information, it's going to take a lot longer. Okay, so it sort of it streamlines the process, and it's good for you for getting information, but it's also good for the patient in terms of trusting you and feeling heard. And then the actual history itself, I'm not going to spend too long on this because this is quite detailed, but we kind of break it up into a few sections, okay? So the main section where we kind of ask the patient symptoms is the history of presenting complaint, okay? So the history of presenting complaint is kind of, if you think about the main thing the patients come in with, let's say it's that it's a headache or it's tummy pain or it's a cough. That main thing that they've come in with, that main symptom, that's what we call the presenting complaint. And then we'll want to take a history about that symptom. So find out when it started, how bad it is, what makes it better, what makes it worse, the timing of it, all of those different types of things. So that Socrates that I've got in brackets there, that's an acronym that we use to ask those questions about that symptom. And we'll touch more on that in future sessions. It's probably too much detail to go in for today, but just remember the first section is just asking the patient about their symptoms, okay? Really easy to remember. You could almost cross out history of presenting complaint and just write symptoms. The second section is about their past medical history. So what medical problems have they had in the past? What surgeries have they had? Have they had this problem before? What have they seen doctors for in the past? So to really get a good idea of what previous medical problems has this person have, and could what they have at the moment be linked to that in some way? Because that can definitely happen. Number 3 is medications. So what medications is someone taking? What are they prescribed from other doctors? What are they taking over the counter? What kind of herbal medicines? Because people take that sort of stuff now a lot. All of those types of things. Um, and then social history is kind of a really underrated one, but really important. But yeah, people in the chat are talking about lifestyle. So yeah, so diet, exercise, smoking, alcohol, drugs, all of that stuff comes into it. But also learning about their life is really, really important here, and a thing that people really underrate because, to kind of the example I always give here is if you've got two different patients with a chest infection, okay, and let's say they have the exact same symptoms and the exact same medical history and they're taking the exact same medications. But one of your patients is let's say he's a 55-year-old builder, okay, who's quite active and he's doing lots of manual work every day. And he lives with his wife and his 2 kids, and he kind of does everything for himself. He's completely independent. But your other patient is a 55-year-old, but they're really frail. Okay, they live at home by themselves and they walk with a stick, and they're quite scared of going out of the house because they're scared of falling over, and maybe they have a carer to come in and help them with the shopping every week. The way you're going to treat those 2 patients is very different because their social situation is completely different. The support they have at home, how mobile they are, whether they're working or not, whether they might need extra support at home, all of those things are very different. And how you're going to treat that patient is also different. So yes, the medication might be the same, but do you give that medication in hospital or do you give it at home? Do you need to give some more stronger medication because that patient might be more at risk of a more severe illness? Do you need to kind of treat the social situation as well? So do you need to help with them organizing carers? All of those things. So yes, it's lifestyle, but it's also that patient's kind of living situation. So who's at home with them? Do they work? How mobile are they? Are they at risk of falling? All of those types of things. And we have a very elderly population in the UK, so that becomes even more important. And then last but not least is family history. So, what things could run in their family, and is that linked in some way? So that's your history, okay? And you need to be asking questions about all of those different things. And at the end of that, as I said, we would aim to end up with a differential diagnosis. So hopefully a list of 4 or 5 things that could could be wrong with the patient. And then we use our other tests to rule in and rule out those things. Last thing I want to touch on before we wrap up is these three things. So we talked a lot about how the history, as well as being important for extracting information and for getting the right diagnosis, um, it's also really important for kind of get establishing that rapport and that trust with a patient. And then we get taught these three areas that we need to cover within our history, which is more to do with the building the relationship and the trust of the patient. And that's ideas, concerns, and expectations. So kind of fairly self-explanatory, but ideas is what does the patient think is wrong? So nowadays, everyone's Googled their symptoms, everyone's put them into some kind of AI software, and they have like something which they're worried about or something that they think is wrong. And if the patient comes to you as the doctor and they have something in their head and they tell you about their symptoms, and you say, no, it's this other thing, but they've not actually had the chance to tell you what they think it is, they will often go away from you thinking, oh, I don't know if he's right, maybe he hasn't thought about the thing that I've thought about. Even if you have thought about that thing, they might not realize that you have. And they'll feel worried and they'll feel unsatisfied and they won't feel good about the consultation. So part of your conversation with them should include trying to get out of them what they think is going on. Maybe they don't have any ideas, and that's fine if they don't. But if they do, it's important for you to draw that from them. And at the same time, understand from them what are they worried about. And if you can get those two things, if you can get their ideas about what's going on and their concerns about what might be wrong, then it allows you to address those things. So it might be, a patient with chest pain who thinks they have a heart problem, which is really, really common. And you say, I understand why you're worried, but based on your history and my examination of you, based on X, Y, Z, let's say, your pain is here and not here, and on examination, this was normal, and on your vital signs, this was normal. Based on those things, a heart problem is really, really unlikely. And then that allows you to really put their mind at ease, and that will really, really build their trust in you because they will feel that this is a doctor who's really listened to everything I've said. He's listened to what I'm worried about, but actually he's given me a really good explanation of why he doesn't think it's not these things. And and sometimes it will be those things and it will allow you to then say, okay, it could be this and this is what we're going to do next. So it really allows you to get that information, what the patient's worried about, and they will really trust you if you can do those things. The last one is expectations. And this one is a bit trickier, but it's really important because nowadays patients will often turn up to a consultation with a doctor expecting a certain thing. Maybe they will want a specific test to be done. Maybe they will want a specific medication. Maybe they will want to be referred to a certain person for further tests. It will really vary, and this will be different between every patient, but it's really important for you to try and understand what that thing is, because if you do something different to what the patient is expecting, that's okay, and that will often be what ends up happening because often patients aren't doctors, so they often won't know what the right thing is. But if they think something different to what you are saying, it's important for you to be able to be in a position where you can explain why you're saying something different. So if the patient is expecting to be referred for a scan and you send them to a physiotherapist, which is something I often end up doing, um, they will often, if you haven't explained why you're doing that, they will often feel unsatisfied, being like, oh, he's just fobbing me off to a physio. Whereas if you say, is there something specific you were expecting? Yeah, actually, I was hoping for an MRI scan. And they say, okay, I understand why you might think that. The reason I'm not doing an MRI scan right now is because XYZ, and I think this will be better for you now. That will make it a lot easier to kind of negotiate that and to help the patient come on board with you. So again, it's about building that trust, that rapport, and kind of good communication essentially. So we need to aim to do these three things within the history as well at some point. And there's different ways of asking the questions, and how you kind of phrase these things will be different in each situation. So I've just got a few questions to round off, and then we're basically done. All right. So we'll hopefully get you guys away on time. So I'll let people join, and then we'll do these few questions. Do you still have to build trust even if they just came for one-time checkup? Well, yeah, you can. You should if you can, because they'll probably come back to see you for something else, and if they trust you, it'll help you. Cool. Right, let's go for it. Nice, cool. I'm glad most of you were paying attention. So it does provide a chat time to chat with the patient. So you're not wrong, but that's not why it's important. Okay, the importance is the diagnosis. So remember, guys, takeaway from that last question was it's that narrowing down that's really important. We do the history first because it narrows down the things that it could be, and then we can use the other tools to kind of really pin down which of those it is and isn't. But if you just go in blind and you start doing blood tests or scans, you're going to get nowhere because there's just too many things that could be going on. If you think about every medical problem that exists, there's thousands of them. Like how are you going to wade through that? Right, next question. Cool. So, yeah, correct. So we want to build a rapport. So a rapport is like a relationship and a trust with the patient, guys. Okay. We don't want to ask too many short, direct questions. Remember, we we want to ask open questions. So remember, I said we want to start with questions where the answer is not yes or no. Okay. We want to say, what's brought you in today? How can I help today? Okay. Those aren't vague questions. Okay. It's important not to be vague. You need to be clear in how you communicate, but you don't want to ask short, direct questions. Okay. Open questions would be in there. Okay. So out of these options, building a rapport is really important. Nice, cool. So that is the medication history, okay? So we'll ask about allergies to medications, what medications they're taking, and people's immunizations would also be in there. Okay, good. So which of these is most likely to lead to an inaccurate differential diagnosis? Cool. Well done, guys. Cool. Hopefully that one was easy. So obviously you want to communicate well. That relationship building, as I've said lots of times, is really, really important. Cool. So that's the end of today's little presentation. Hopefully, you now have a better idea of what history taking is. Um, so really important tool that we use. As I said, I think it's by far the most important skill you need to have as a doctor. If you can't take a good history, you're probably not a great doctor, to be honest with you. So, really, really important skill, and hopefully this will help you to kind of benefit from the next few sessions as well, because when we talk through cases, it will help you to understand why we're taking a history first and then examining, then doing tests and all of those different things, and it helps to kind of understand the sequence of things. But yeah, I hope that was helpful, guys, and we'll see you tomorrow evening, 7:30, to go through a little bit of a case. All right, take care, everyone. All the best.